Okay, good morning, everybody. It is really a pleasure to be here with you, with my colleague. And now we will start this session about liberation from mechanical ventilation. And it is really a pleasure to introduce the first speaker, Lise Picard. Please, Lise, thank you.
Good morning. Then, weaning from mechanical ventilation. What are the current guidelines? These are my disclosures. Nothing is related to this presentation. First of all, liberation from mechanical ventilation. What does it mean? In fact, it's a global process with different aspects. First, weaning the patient from the ventilator, then extubate. And of course, and this is clearly part of the process, we have to prevent extubation failure. And the challenge with liberation from mechanical ventilation is to find the balance between not being too early and not being too late. Because if the process is too fast, then the patient is going to be reintubated because of persistent gas exchange abnormalities or persistent respiratory distress with inability to sustain the respiratory work of breathing that is needed. And reintubation is associated with more ventilator-associated pneumonia, with prolonged ICU and hospital lengths of stay, and with increased mortality. And oppositely, prolonged mechanical ventilation has a lot of adverse effects. This is also associated with increased in ventilator-associated pneumonia, of course, with increased ICU and hospital lengths of stay, with increased mortality. But also, and this is very important from the patient point of view, with long-term sequelae. And those sequelae are altered quality of life, are persistent physical disabilities, and also persistent psychological problems as anxiety, depression, and even loss or decrease in the performance for daily life with mentation. Then, what do we have to help us managing this problem and finding this balance? First of all, we have the report of Consensus Conference on Weaning that was published in 2007, which means 18 years ago. And this was a consensus conference that put together 11 experts who had access to publications and who did recommendations. But this was not a systematic literature review. And basically, what is in this paper that reports the discussion that were held between those experts? Then there are a lot of important things regarding our current standard practice. First of all, it's clearly written that weaning and liberation from mechanical ventilation is a systematic step-by-step process, one thing after the other. This process should start as early as possible to be fast. This process is successful only in the absence of reintubation, of course. And if we look a bit more at the steps, we can say that first we have to find the earliest possible moment where things are going better, when the patient is stable. Then we have to assess the readiness to wean, which means criteria that allow your patient to be able to sustain a spontaneous breathing trial. And in this paper, it's clearly underlined that the spontaneous breathing trial is an essential milestone of our liberation process, because it's going to test whether your patient, of course, can breathe without the assistance of the ventilator. And in this paper from 2007, there is no recommendation about what test you should use. You can either use a T-tube or a pressure support ventilation test. And there are also other important points in this guideline. And the experts proposed criteria for the readiness to wean. And if we simplify a bit, we can say that basically the situation has to be improved compared to the time of intubation, that the patient must be hemodynamically stable or at least compensated, that oxygenation should be good, that the ventilatory function should be good enough, and that the mentation should be okay. And they also specified criteria for what we should consider as a spontaneous breathing trial failure. And again, we have very general elements. The patient should stay stable from the state of consciousness, should not develop a respiratory distress during the test, should not be dyspneic. This is interesting. Oxygenation should remain okay during the test, as well as the ventilatory function and the hemodynamic status. And already in this recommendation, the experts clearly said that in case of spontaneous breathing trial failure, we have to look for the cause and to treat the cause if possible. Another thing that is already in this task force document is that weaning can be classified as simple, difficult, or prolonged, depending on the duration of the weaning process and on the number of the spontaneous breathing trial you need to liberate the patient from the ventilator. This was a bit refined later on based on a big observational study that is the WIN study, essentially performed in France and included nearly 3,000 of patients. And in this big cohort, the authors observed that basically 57 of patients could be weaned 1 day after the first SBT trial, which is simple weaning. 10% of the patient could be weaned within 1 week after this first spontaneous breathing trial. This is difficult weaning. And a bit less than 10% were those patients with prolonged weaning were still connected to the ventilator more than 1 week after the first spontaneous breathing trial. And of course, simple weaning is associated with lower mortality compared to difficult and compared to prolonged weaning. Now, what about the real life? We have those standard of care that are described, but what do we do in our practice? And we have a lot of information about the current practice on weaning coming from the WINSAFE study. The WINSAFE study is another big observational study. This time it involved more than 400 ICUs everywhere in the world and nearly 6,000 of patients. And those patients were intubated at least 48 hours when they were observed regarding the way the clinicians perform the weaning process. And there were some elements that were quite surprising. First of all, and this is overall a good news, 65% of the patients who are intubated more than 2 days are finally successfully separated from the ventilator. The other ones usually die before this step or remain sometimes ventilated. What was strange in those data is that we don't really do all the steps that were described in the 2007 consensus conference. And as you can see, a spontaneous breathing trial was performed in only 66% of the patients. A lot of patients were extubated directly without prior spontaneous breathing trial, about 20% of the patients, and quite a lot of patients underwent direct tracheostomy without having had at least one spontaneous breathing trial. This was clearly a surprise when analyzing the data. What was not a surprise is that we found again the different class of weaning, simple weaning, intermediate or difficult weaning, and prolonged weaning, and the proportion of the patient in each group were nearly the same as the one from the WIN study I just showed you before. There is something else that is interesting in those data. There was a recording of all the steps that were described in the consensus conference. You can see all those steps. In yellow, the signs of spontaneous breathing. In red, the weaning eligibility criteria, readiness to wean criteria are fulfilled. In blue, the first separation attempt. in green, the winning success. And as you can see, there is a delay. There is a delay between the time when the criteria are okay for the willingness to win and the first separation trial. Overall, this delay is not so big. It's about 1 day in median, but in 22.4% of the patient, this delay was of at least 5 days. This is a lot. And very importantly, the time interval between the presence of the winning eligibility criteria and the first separation attempt was associated with winning failure. Then we are too slow. We also fail more often. This is important. And how can we be better? Then we can look at the factors that are associated with winning delays. There are patient-related factors, not easy to influence that. But there are factors that are strongly associated with those delay in winning. And basically is the use of continuous neuromuscular blockers administration and deep sedation. It's not surprising, but it was strongly associated. Then what can we do to be better? We can be proactive in screening. This is essential. We have to use winning protocols because winning protocols, that is a systematic approach applied by everyone in the unit, are associated with a reduction of the mechanical ventilator duration and the ICU stay. And we definitely should reduce sedation. And those two last aspects, which are the most important ones if we want to be better with winning, are not mentioned in the task force document in 2007. Then probably we should do another document quite soon. And what about guidelines about winning? Basically, there are not a lot of guidelines available. There is one that was published in 2017, and this was a common work together with the ATS and CHEST, North America. This is a usual guideline with PICO questions, systematic reviews, grading of the evidence, and then writing the recommendation. It's split into paper, but it's the same work. And what do we have in these guidelines? Then a first recommendation. We should use pressure support spontaneous breathing trial instead of T-tube, because winning is faster. We should minimize sedation. This time it's written. We should use prophylactic NIV to prevent reintubation in patients at risk of reintubation. We should use early mobilization. I don't know why it is here, but it's in the guideline. We should use a winning protocol, also important point as said, and two recommendations about the cuff leak tests in at-risk patients. Very importantly, if you look at those recommendations, we have 3 recommendations that were considered as having a moderate certainty of evidence. All other ones had low certainty of evidence. And in the end, there is only one strong recommendation, the one about using NIV after extubation to prevent failure in at-risk patients. All the other ones are conditional recommendations. Then I think we can say that at that time at least, winning is more an art than a science. But we have new data. And as an example, we can present the data from the study of Arnaud Thiel, who compared spontaneous breathing trial with T-tube or pressure support ventilation. And very interestingly, we see that there were, even if there were no difference in the number of ventilator-free days at day 28, there were also no difference in reintubation rate, and using the pressure support ventilation strategy, there were more patients classified as simple weaning, basically weaned after the first SBT, and less prolonged weaning. Then using this strategy, in patients who were at risk of failure, that was not all the patients, we had an advantage in favor of SBT using pressure support. And we also have emerging data suggesting that dyspnea is a problem. Dyspnea is a problem for the ventilated patient because it's uncomfortable and it also could cause a trauma for the future. And dyspnea is very frequent in intubated patients, and especially during our spontaneous breathing trial, that can be an issue. And very importantly, it was demonstrated that the density of dyspnea, which means the number of episodes of dyspnea divided by the duration of mechanical ventilation, is associated with more post-traumatic stress disorder at day 90. For our patient, this is important. Then, as a conclusion, I would say that to help us separate our patients from the ventilator, we only have one consensus conference, a very old one, and one guidelines with nearly nothing in it. Winning is thus still more art than science. But we have a lot of new data, and my colleagues are going to show a lot of new data in the next talks. There are new aspects, and probably, definitely, we should include dyspnea, our future guidelines, and definitely new winning guidelines are needed. The work is ongoing between the ERS and ESICM. Then, in the next 1 or 2 years, we should have new guidelines. Thanks a lot for your attention.
Thank you, Liz. Great talk. Any questions from the audience? I will start with one. I have a curiosity. Don't you think that perhaps when we are talking about weaning, we are just focused too much on the lung and not on the hemodynamic muscles, consciousness, and perhaps we have to try to approach the problem also from other point of view. What is your opinion?
For sure, and for sure, if we consider that weaning is even a more global process, because personally I think that weaning starts nearly as soon as you intubate the patient, and there is something that we have to focus on is the transition phase between controlled and assisted ventilation. And in this specific phase, all the aspects, hemodynamic stability, diaphragm protective ventilation, and lung protective ventilation should be applied. And I think that we should insert that in the weaning process. Definitely, yes.
Totally agree with you. Thank you. Yes, please. A microphone is coming.
Do you think that weaning protocol is marginally different for patients who have got obstructive airway disease, as for example COPD, asthma, and a weaning protocol for ARDS?
And regarding protocols, the interest of protocols is highly dependent from the control group you have. Basically, if you are already very good with weaning, you do all the steps every day for every patient and for every pathology. For example, different protocols for ARDS and COPD, because there are also arguments saying that we can extubate COPD patients much earlier with a transition to NIV. Then if you already have a very systematic procedure, you are not going to gain a lot doing protocols for everything. But in real life, we know that we don't do everything every day for every patient. And using a protocol is going to systematize the approach. And that's why, in meta-analysis, it's an advantage to have protocols.
A study by Stubbin long time back for COPD, he has done extubation early and NIV uses, and extubation delayed without NIV, and he could establish the fact that in COPD we should early extubate them and put them on NIV, not for other group of patients. Do you agree with that?
Yeah, for COPD patients, we should extubate early, and there is quite strong evidence for that with a transition to NIV, as long as we can perform NIV safely. That's the point. But yeah, there is an advantage of being very fast with the weaning strategy in COPD patients. Agree.
Thank you.
Thank you very much, Liz. We have to move on because of the time. So it's my pleasure to invite the next speaker, Professor Oriol Roca from Barcelona. He's going to discuss with us if winning strategies affect outcome.
Good morning, everyone. I would try to convince that different winning strategies would be associated with different outcomes depending on how you apply it and how you perform. Why is important to correctly wean our patients? Because if we are wrong, we will increase the reintubation rates, and as you can see, it is constantly associated with higher rates of mortality. So we have to try to do our best to correctly wean our patients and avoid reintubation. And I want to be a little bit provocative, because this is a recent paper where different phases of mechanical ventilation, similar to the ones that Lee showed before about the paper of guidelines in 2007, but now here appears the transition phase, assisted ventilation, which is mixed with weaning phase. Depending on when you decide that weaning starts, you would consider that this part of transition would be shorter or larger, but consider that every day more and more we are trying to decrease the time of controlled mechanical ventilation, and every time more and more we are trying to give more post-extubation respiratory support, which makes that this weaning phase, traditional cold weaning phase, is shorter and shorter and shorter, right? And one interesting fact is that during that phase, there did not suggest any kind of monitoring, which is quite a bit surprising for me, because how you decide if the patient needs to be reintubated or not? Only like clinical variables? Probably yes, you have to hold the whole picture, but the whole picture is not only what you see, it's only what you cannot see, and monitoring devices provide to you. So this is what we should take care about during the transition phase. It's probably, for me, it's the start of the weaning phase, but it's only my opinion, and I wanted to be provocative, so this is why I put this thing. Liz also talked about assessing the readiness to wean. I think that we could group all these variables in 4 different ones: the resolution of the disease, adequate oxygenation that we could discuss about the threshold that we use, adequate level of consciousness, and adequate management of the secretions. But if we look specifically to the oxygenation thresholds and we go back over time, we will see that at the beginning of the 21st century, we consider that to start weaning, we need an FiO2 below 0.4 and a PEEP below 0.5. How many patients do you have in the ICU now ventilated with PEEP less than 5? In my ICU, PEEP than 5 means that you can automatically remove the tube, maybe. Then we move a little bit further and say, okay, maybe 5 is too low, and then we should use maybe less of 10 to consider to wean the patient from the mechanical ventilation. Then we move a little bit further and we decrease the PF from 180 to 150, and keeping the PEEP around 8. And then we move a little bit further according to the data that Liz has shown you from the WinSafe study that says that if we had used these criteria, probably we could be able to avoid this delay in the liberation of mechanical ventilation. And more recently, there is another paper published online in the Blue Journal by the same group, saying that on average, if you use the criteria, a single criteria to start weaning, considering those patients who have a PF ratio above 150, on average, you may decrease by 7 days the duration of mechanical ventilation. So we are every day more and more and more aggressive in terms of when to start decrease sedation, start the transition and moving to the patient to the this weaning phase. What about the SBT? We use the SBT to identify those patients who are going to fail, trying to mimic the post-extubation condition. But remember that the post-extubation condition now is not the post-extubation condition 20 years ago. Now we are using NIV, we are using high flow, so we are providing a smoother transition from invasive to spontaneously breathing to our patients. So we don't need maybe to push so hard in the way that we perform the SBT. And if it's too hard, we will prolong mechanical ventilation, and this might be associated with an increase in mortality. If it's too easy, we will have a higher reintubation rates, and we also will increase mortality. So we have to balance in between these two extreme situations, I would say. I would just wanted to show you a couple of studies. This is a study by a Spanish group that compare high effort, high intensity strategy performed by 2 hours of TPs comparing 30 minutes of PSV. Obviously, you can extubate the patient earlier with PSV, which makes a lot of sense. But the concern was, is the reintubation rate higher? No, it wasn't. So in that sense, 30 minutes of PSV, it's better than 2 hours of TPs. But 2 hours of TPs might not be the control group. And the group from Arnotti, who is here and will speak later, performed a study that Liz already showed. I will go rapidly on that. The good thing of that is that they can stratify the patients only using 3 criteria that can be very easily assessed at the bedside. And this is one of the advantages of his strategy. Because I'm not a smart guy, and I only see 65, chronic respiratory disease, chronic heart disease. Okay, if the patient has one of these, it's at high risk, right? So they compare TPs and pressure support. And as you can see, with pressure support, you can extubate patients a little bit faster, as Liz showed before. More patients on simple weaning, less patients on difficult weaning, and without increasing the reintubation rate. So the first conclusion would be PSV might be better than TPs, right? The other issue is, should we, after this SBT trial, do we need patients for a rest before extubation? And this is another study performed in Spain that says that if you give an hour for resting after the SBT, the reintubation rate decrease up to 5%. But consider that in most of these patients, the SBT was performed using TPs, which is a hard SBT. So maybe with PSV, we do not need to make this patient rest, and we could be even more faster. Although 1 hour would not make a difference between the outcomes, I guess. Anyway, what we did with Gonzalo Hernandez was some kind of combined and pragmatic approach, combining different screening strategies with different SBT trials. And I really like the way that Remy Coudreau presented once, which I really believe was much more understandable than the way that we wrote the paper. So I will show you how Remy presented, because when he did it, I said, oh my God, why we explain it in a way that was so difficult to understand? Because now it's easier. We say aggressive and conservative. But aggressive means that the SBT is performed earlier and in an easier way. So we would be more aggressive in terms of arriving to extubate the patient. The screening was compared between a usual screening, PF 150, but with a FiO2 of 0.4 and 8. This is the threshold that the patient needs to meet to start decreased sedation compared with an earlier one, with an FiO2 of 0.5 and a higher PEEP. And in terms of SVT, we perform a usual, at that time, pressure support of 5 without PEEP, or pressure support of 8 with a certain level of PEEP during 30 minutes, not more than 30 minutes. And we recruit almost 900 patients. One of the groups should be stopped, as I will show you later on. And the outcomes was the time from randomization to extubation. We wanted that the earlier and easier SVT would perform a shorter time until from the randomization to the extubation. And these were the main results. As you can see, earlier screening, regardless the use of SVT, seems to perform faster than the usual screening. So FiO2 0.5, PEEP of 10, you can start decreasing sedation in patients with acute hypoxemic respiratory failure. But what happens with the SVT? And the predefined stop criteria for any of these groups was arbitrarily defined by us. We did not accept that reintubation rate was higher than 20% in any of these groups. And as you can see, the reintubation rate after including 100 patients in the earlier screening easier SVT is pressure support of 8, PEEP of 5, was 20%. So at that point, we stopped including patients in that group. We do not know what would happen, and we may discuss if 20% is a criteria that we should use, or we would accept 25. I don't know which is the threshold of reintubation that we need to accept in our ICUs, but at that time, this was the decision that we took. I want to say a couple of things of fluid balance. I know that Martin would address that later on, but I think it's very important. If you have a positive fluid balance, and this is a traditional study from the group of Andres Esteban published in CHEST 20 years ago, if you have the reintubation, the winning success rate, the reintubation rate was clearly related with the fluid balance that the patient has on the previous days of ICU admission. So before starting SVT, or in the meantime that you are decreasing sedation, be aware that you need to have at least, that you need to avoid a positive fluid balance. And the same happens when you are transitioning from control to assist or pressure support ventilation. Fluid balance is a variable, positive fluid balance is a variable that was independently associated with failure. These are patients without acute hypoxemic respiratory failure or ARDS, so healthy lung, let's say, more than 1,000 patients from the Ventila cohort. And it is constantly and independently associated with PSV failure. What about post-extubation respiratory support? I don't go deeply on that. This is a nice algorithm that Gonzalo Hernandez and Nick Hill published in Current Opinion of Critical Care this year. I like the idea of the fact that the higher is the risk, the more conservative approach to the weaning you need to have, and the more frequently NIV you should use. So more conservative in the weaning, but more aggressive after extubation, preventing the apparition or the occurrence of acute hypoxemic respiratory failure after extubation. This is the concept of the whole diagram that you have here. And finally, just one word about tracheostomized patients. This is a paper that we published in the New England 5 years ago, that compared the 24-hour capping trial with intermittent oxygen therapy as a criteria for the cannulation, compared with a criteria based on number of times that the patient requires suctioning for secretions. If the patient required less than 2 during 8 consecutive hours for twice, it means that you would be able to decannulate the patient. And doing that, only doing that, which means a stupid thing, it's a very easy thing to do. We could decrease up to 7 days the duration of the invasive, let's say, mechanical ventilation or the weaning process. So just to summarize, because I'm running out of time, of course, weaning is a complicated process that for sure influences outcomes. PSV might be better than TPs, for sure, for the data that we have until now. We will wait what the guidelines say. Patients with low intermediate risk may benefit from earlier start of weaning with an easier SVT strategy. Do not forget the importance of post-extubation respiratory support, and maybe 24-hour capping trial may delay the cannulation in tracheostomy patients. Thank you very much, and I will be happy to take any questions.
Thank you very much. We have time for one question from the audience. Questions? Microphone here, please. It's coming. Here. Thank you.
Laube from Switzerland. Are the pressure support ventilation trial done with automatic or without automatic tube compensation?
This is one of the typical questions that always appears. I would suggest in these trials were done without. I would suggest that we have no data about comparing with and without, but I would suggest to use it, even for normal ventilation, which makes sense, physiologically speaking, but in these trials were performed without.
Maybe one more question, if any? No? Okay, so it's better if we move on. Thank you very much.
Thank you very much.
Great. Now we move on with watch the CVP during trial with Dr. Becker, please. Thank you.
Thanks. And great introduction by Oriol about his fluid balance. And a question from the chair earlier on about the, let's say, cardiovascular effects of weaning. So CVP and weaning from mechanical ventilation. These are my possible conflicts of interest, nothing related to this presentation. There's a lot about, let's say, the cardiac, the cardiovascular, the hemodynamic responses to weaning. So there is not a lot new, to be honest, but what you have to remember, and it depends a little bit on how you wean, but if you take a patient off significant positive respiratory support, weaning is exercise. And this is old stuff. It has not been repeated. So if you take a patient off a mechanical ventilator, the oxygen demand of this patient, and especially, of course, of the respiratory muscle, will increase. The only way to meet the increased oxygen demand is to increase your cardiac output. If you cannot increase your cardiac output, then you will fail. Not, let's say, seconds later. It could take some time, but ultimately you will fail. And the increase in oxygen demand is about 25, 30%, something like that. That's what we found when we did this study in Santiago, Chile. If you measure SCVO2 and you put a patient on a ventilator, so the opposite, if you relax the muscles, if you, let's say, create a situation wherein the patient does not need to do the exercise, then, of course, the amount of cardiac output you have will be redistributed, and your SCVO2 should go up as a marker of, let's say, a better balance between oxygen demand and supply. And that's what we showed. If you put patients on a ventilator, your SCVO2 goes up. And so these both studies underscore the effect that mechanical ventilation can reduce oxygen demand. Weaning from a ventilator is an increase in oxygen demand, and so exercise. And so there are hemodynamic, cardiovascular consequences to both of them. This is an experimental study, and this is, they looked at the cost of breathing and then more in the sense of, do you create tissue ischemia? And this is experimental tamponade. If you induce experimental tamponade in an animal and you have the animal on a ventilator, the lactate levels rise way faster and higher in the animals that breathe spontaneously. Of course, because you limit the compensation by an increase in cardiac output, and so by definition, if you increase demand and you limit the response of cardiac output, you will get ischemia. The other way, if you want to have a patient off a ventilator who has a cardiac, let's say, dysfunction or failure, and so a patient on an intra-aortic balloon pump has, let's say, compromised cardiac hemodynamic functions. If you try to wean them from the balloon pump without mechanical ventilatory support, that is less effective than when you take away some of their oxygen demand by keeping them on a ventilator. It doesn't mean that all these aspects of mechanical ventilation or respiratory support need a ventilator, but we have no studies whether, for instance, pressure support or high-flow nasal or non-invasive stuff like that could do the same trick. But it's to underscore that weaning requires a cardiovascular cardiac response to be successful. So in summary of these, let's say, introductory slides, spontaneous breathing increases oxygen demand. Transition from mechanical ventilation to spontaneous ventilation increases oxygen demand and has to be met by an increase in oxygen in cardiac output, because that's the only way we deal with increases in oxygen demand. You cannot increase your, let's say, capacity to run out of this room by breathing a little bit more oxygen. If you cannot increase your oxygen, your cardiac output, and there is a fire here, and you try to run outside this room, and your heart cannot compensate, you will fail. And so that's an important aspect. Decreasing myocardial support when you want to wean from a ventilator, that may be an important aspect as well. And cardiac function may be stressed by the induction of myocardial ischemia. That's the old studies where they show that patients get myocardial ischemia when they increase their oxygen demand. A passive leg raising result is related to weaning-induced cardiac dysfunction. If you do a passive leg raising and you are fluid unresponsive, you're in a hypovolemic pathological state. If you then induce a mechanical ventilation withdrawal, you will have an increase in venous return, which might result in a worse outcome. And that's basically what was shown. Failed spontaneous breathing trial due to induced cardiac dysfunction was diagnosed if the patient exhibited an associated increase in cardiac wedge pressure during the SBT at 60 minutes. So this is a limited, let's say, explanation or association between cardiac failure. But as you can see, in the 15 failed spontaneous breathing trials, 11 had a passive leg raising plus, so were fluid responsive, whereas in the other it was only 1. Okay, so if you look at the same study, if you look at the changes in cardiac index due to the passive leg raising, you see that there is a difference in the cases without weaning-induced cardiac dysfunction and the cases with weaning-induced cardiac dysfunction. But what I would like to draw your attention to is the effect on CVP. The patients that failed had, in this study, an increase in CVP from around 10 to around 13, 14. And that makes sense because if you decrease intrathoracic pressure and you increase oxygen demand, you will have an increase in venous return. If your heart cannot deal with the venous return is on the right side. The only possibility the heart has to compensate is increase central venous pressure to decrease the venous return by an increase in central venous pressure. So that's a physiological mechanism to protect. And so that's why we did this study, a very simple study where and the weaning was always on TPs, so it was a dramatic, let's say, takeaway of intrathoracic pressure. There was, whatever it was, the PEEP to basically 0 and no inspiratory support, so significant increase in oxygen demand and a full takeaway of the resistance to venous return. And we measured at 2 minutes. So not like waiting for a long time. We measured the CVP response 2 minutes after disconnecting them from the ventilator. And that's important because that's the immediate stress response to the circulatory system. Because if you wait and you get adaptation, you get an increase in oxygen extraction ratio to take care of the increased oxygen demand, you get a completely different equilibrium that could still be, let's say, indicative of a weaning failure, but not immediately. It's a much later response. And basically what we found is if you increase your CVP at 2 minutes, you're much more likely to fail your spontaneous breathing trial than when you don't increase. So this is the weaning success, no change in CVP, 10-10, baseline in the ones that failed extubation, 8 to 12, that's a 50% increase in CVP at 2 minutes. And we could draw a nice association between the change in CVP on the x-axis and the probability of weaning failure from 0% to 100%. And as you can see, the higher the increase in your CVP within the first 2 minutes, the higher the chances of extubation failure. And so if you increase more than 5 millimeters of mercury, there is on average, more than 60% chance that the patient will have an extubation failure. Okay, if you take it from that, what is driving the venous return? It's the intravascular volume. It's the mean systemic filling pressure. And I have to contradict to Oriol, that has nothing to do with your fluid balance. If you have a 10-liter fluid balance, the 10-liter cannot be in your circulation. You would explode. So the 10 liters, most of the 10 liters is in peripheral edema. That doesn't mean that the immediate positive fluid balance, let's say an hour before, because you just gave a fluid resuscitation of a liter, has no consequence. But the fluid balance in and of itself does not predict your intravascular volume, and especially not your mean systemic filling pressure. But if you take away respiratory support and you increase venous return, you will have to increase your mean systemic filling pressure to create the gradient and have this increased venous return. If your right heart is completely filled and you have an increase in venous return, the right heart will fail, and the symptom is a rise in CVP. And so that's why we said, okay, if we in this study, a large study that we did in Mexico, you find that in 2 minutes, an increase in CVP is, let's say, indicative of weaning failure, that's cardiac dysfunction, let's try to prevent all of this. And so we compared two things. Ricardo Castro, who defended his PhD thesis last year in Rotterdam, and we said, okay, let's try to do the thing that we have always been doing, create a negative fluid balance, and in the other one, create a patient that is fluid responsive before you extubate. And so basically take out so much fluid that if you do a passive leg raising, that the patient is fluid responsive. That's a physiological state. Being fluid unresponsive is a pathological state, whatever your CVP. And so that's what Ricardo did in this study published last year. Small number of patients, so I mean, this is not a huge signal, but it's just to underscore the principle that we were trying to make about the cardiovascular effects of weaning. If you chase a negative fluid balance or you chase a state of fluid responsiveness, the time to endpoint, the time to a spontaneous breathing trial, and especially the time to extubation in hours, 57 to 26, so 50% reduction. And it makes perfect physiological sense. Doesn't mean that if you do this in a study in 1,000 patients, you will have the same impact of 50%, but it's to underscore the physiological principle of weaning, extubating a patient on a pressure support or on a positive pressure. It could mean that you could prevent this failure by adding positive pressure, non-invasive pressure with a little bit of PEEP. But that doesn't take away the chances of failing when you take away this pressure if the patient is fluid unresponsive. So it makes, let's say, physiologically perfect sense. So, in conclusion, fluid unresponsiveness before a spontaneous breathing trial and cardiac dysfunction during a spontaneous breathing trial are associated with weaning failure. An early increase in CVP is a bad signal, and early is 2 minutes. And the higher the increase in CVP, the higher the chances of a weaning failure. And we think, on a physiological basis, it makes perfect sense to create a state of fluid responsiveness in a patient before you even start the spontaneous breathing trial. Thank you very much.
Great talk. Thank you very much. Any questions from the audience?
Of course.
Please.
I think that we were saying more or less the same from a different perspective, one from the lung and the other from the hemodynamics. The way that we could show the impact of fluids on the lung, not on the hemodynamic performance, was it was an observational approach, and they were switching from control to pressure support. So in fact, we were not removing the tube, but the message behind that is that you need to keep the lung dry if you want to succeed on the transition from control to pressure support ventilation. But I fully agree with you with the fact that the hemodynamic impairment generated by this increase in benefit return for sure plays a role in the success of weaning. For sure.
Well, that's an important context, because if you have a patient with 30 ml per kilo of extravascular lung water who is fluid responsive, do you think you can extubate a patient with any positive support? Forget it. I mean, that's a theoretical thing, of course. So it makes sense. Fluids in the lung are related to fluid balance and capillary leak. If you add a cardiovascular, let's say, element to that, an increase in venous return, you will definitely fail. The interesting thing is, and I'm discussing with Ricardo to do the study, what's the effect of extravascular lung water in a fluid-responsive patient when you do a weaning trial?
Lise, please.
I have an additional question. I would like to come back to the correlation between the increase in CVP and the prediction of failure. Shouldn't we look at this based on the total fluid balance, cumulative fluid balance, and stratify the patient maybe?
No, we didn't find the relationship. So we tried to find a relationship between fluid balance and CVP, and there is no relationship, which makes sense. Because if you are, let's say, filling up a patient to a status where he or she starts to increase his CVP, you're inducing cardiac failure already on the ventilator. And so by the effect of giving volume, you increase mean systemic filling pressure to a certain point, and at that point the volume disappears into the periphery. That's why your patients get edema. But there is we didn't find a relationship, small study. We didn't find a relationship between total fluid balance and the baseline CVP.
Sorry, I'm really sorry. I'm really sorry. We just don't have time because we have a satellite symposium, so we need to move on. I'm sorry. So I would like to invite... thank you very much, Ian. I would like to invite our next speaker, Martin Dress, from Paris, France, who will discuss about diuretics in the weaning phase. Thank you.
Yes, thank you for the introduction, ladies and gentlemen. It's really a pleasure for me to be here. I really would like to thank the Committee of Organization for the invitation. So I'm going to have a difficult task, trying to find a compromise between the previous speaker. So we are going to discuss about the use of diuretics. There are my conflict of interest here on this slide. So I think it's important to go back to physiology. It has been already discussed earlier, but on this slide, I wanted to highlight that the issue of the outcome of weaning is really a balance and equilibrium between the loads, the respiratory loads that applied to the respiratory capability. And what you can see is that, of course, as it has been already discussed, you have a pulmonary edema. You may increase the respiratory loads, which may lead to an imbalance between the loads and the respiratory capacity, which, at the opposite, is the respiratory drive of the patient. So, again, the sedation may play an important role. And the respiratory muscle, of course, are very important here. And if we go into the physiopathology of weaning failure from cardiac origin, on this slide I wanted to highlight, it has been already discussed, the role of systemic venous return that increased during spontaneous breathing because of the decrease in intrapleural pressure because of the contraction of the respiratory muscle. And in some cases, in particular in patients with COPD, for instance, or right ventricle dilation, you may have some interdependence between the left and the right ventricle, which, in addition to cardiac ischemia, for instance, hypoxemia, hypercapnia, of course, distress could lead to an increase in left ventricle pressure, and at the end of the day may lead to weaning-induced pulmonary edema. So just to make it clear, because I think it's not always easy to understand that, I think this curve here is a nice illustration of the relationship between the venous return, so it's the volemia. It's a way, it's not really fluid balance, it's really the amount of fluid that is in the vessels. So it increased during the weaning trial because of increase of venous return, and it's in a relationship between the pressure inside the left ventricle, right? So you see, of course, that you have two portions of the curve. A first one here, it's preload reserve. So it means that if the venous return increase, it won't be associated with a huge increase in the pressure. So no cardiac dysfunction, no pulmonary edema. And here, the use of diuretics probably would be useless, right? Because you won't have a significant change associated with the pressure. Whereas if you are on the sharp part of the steep part of the curve here, you can understand why diuretics may be useful. Because you have this huge increase in venous return, which will be associated with an increase in the pressure. So the surrogate of the left ventricle filling pressure is PAOP, the pulmonary occlusion pressure. Of course, we cannot measure that in our patient because it's quite invasive to use a pulmonary arterial catheter, but it's just a physiological way to understand the principle of using diuretics. So the study here has been already presented before, so it's going to be much more easy for me. Just to say that what we did in this study is that we performed the passive leg rising before the SBT, and we monitor the cardiac output to discriminate patients with an increase in cardiac output during the passive leg rising or no change in cardiac output during the passive leg rising. This is what you can see here, the change in cardiac index during the passive leg rising. And then the patient had a spontaneous breathing trial and were defined with cardiac dysfunction or not, depending of the increase in PAOP, the pulmonary arterial occlusion pressure. So the cutoff that we found to discriminate patients with a cardiac preload reserve and the risk of pulmonary edema was around 10%, because you see that those patients with winning-induced cardiac dysfunction had no change, very low, 4% of cardiac output change during the passive leg rising, really meaning that those patients had no cardiac preload reserve. But actually, it's quite a complicated method. I think you need to assess a cardiac output change during a passive leg rising. So either you use a thermodilution technique, either you can use cardiac echo, but it's not so easy. And the fact is that if we look at big data, here it's two observational studies that were conducted in France, near Paris. You see that the prevalence of winning-induced pulmonary edema is quite high, quite consistent between the two studies. There were not exactly the same population, of course, two different sites, but we can keep in mind that the prevalence is around 60%, which is quite high. So there is a kind of rationale to say that we could use diuretics in all patients without doing this hemodynamic approach, just to decrease the preload reserve in order to avoid the occurrence of winning-induced pulmonary edema. This slide has been already showed because fluid balance clearly is an important determinant, even though I completely agree that it's not the main one, and clearly what is important is to assess the preload reserve, which is not so easy. But you see that fluid balance still is important because it is clearly associated with mortality in this study that was performed on 400 patients in the UK and in Canada. It's a retrospective study, but you see that fluid balance is really important and may be associated with survival of the patient. So clearly there is a strong rationale for the use of diuretics. This is what I will discuss. I just wanted to mention this nice overview that was published recently in Intensive Care Medicine. Interesting review that provides a nice overview on what kind of diuretics, which dose, what can we expect. But I think it's important to highlight that the use of diuretics may have some adverse events, which is a reason to probably not give diuretics to everyone. So there is still a rationale to try to discriminate the patient who may benefit from diuretics or not. This is really the big question. You see, in some studies, diuretics are associated with adverse events. Here, hypokalemia, for instance, or metabolic alkalosis. So we cannot give those treatment without monitoring, of course. So I just want to take some time on this study because it's probably one of the most interesting study on fluid strategy in patients in the ICU, trying to maintain them dry and trying to liberate them faster from the ventilator. This study was performed on 1,000 patients. It's a randomized controlled trial, and two strategies were tested. You see a liberal fluid strategy or a conservative. So conservative is dry, so let the patient dry. And the problem of this study to be implemented in our current practice is that it used, you see the pulmonary arterial catheter, and maybe the central venous line is much more easy to use, but putting a pulmonary arterial catheter, I think, is not so easy, and much more difficult is to have a very valid measurement of the pulmonary arterial occlusion pressure. But still, the concept is interesting because they compare these two kinds of strategy with, you see, an algorithm. I think you will agree with me, it's complicated algorithm. Again, the concept is very interesting, but not so easy to implement in the clinical practice. Just to highlight and to explain how did it work. You see, let's say you have a patient with a mean arterial pressure that is quite normal. You measure the cardiac index because you have the pulmonary arterial catheter. And based on the value of CVP and POP, you would decide to either give fluids or either to give diuretics. So it's really a nice concept, and the fact is that the study was a positive study, which is quite rare in clinical RCT in the ICU. You see, if we look at the survival of the patient who were treated with a conservative strategy, so less fluid, a very dry strategy, had a better survival. And what was also interesting to see is that they had much more ventilator-free days. It's almost 2 days. And you see they receive much more diuretics in this group than in the conservative group. So it's clearly a validation for using diuretics, but here again they really wanted to have a strong approach with a very sophisticated device that is a pulmonary arterial catheter. There are some other experience that has been reported. I will skip that for the sake of time. Just to show you this study that was maybe more pragmatical. It was performed in France. And here the idea was to guide the administration of diuretics based on the BNP, which is a marker of cardiac stress. So a clinician randomize a patient either with a usual weaning, so they could give diuretics to the patient based on their clinical routine approach, I would say, or each day the patient had a BNP sampling, and based on the level of BNP, furosemide diuretics were given to the patient. And you see that there were patients who were treated with a BNP strategy had a better outcome in terms of successful extubation. But I wanted to stress out this is really that here, patients who were treated with a BNP strategy had a much higher cumulative fluid balance. So we have the proof of concept here. If you give diuretics to the patient, here based on the BNP, you will obtain more positive fluid balance, negative, but the total amount is higher, of course, as compared to what we do in our routine practice. So obtaining that, a higher urine output is associated with a better outcome. So you see here the results. So, because BNP is not cheap, it requires to be sampled every day, we wanted to assess a more simple approach. This is what we call the PCT study, for Preventive Curative Therapy Study. And the idea was to compare two approaches. Preventive, so you give diuretics to patients as soon as they have these stability criteria, good oxygenation, no problem in terms of hemodynamics, and as soon as you decrease or you stop the sedation. Then the patients are randomized. If they are in the preventive group, they receive diuretics based on this algorithm, based on the urine output. Okay, so every 3 hours the urine output is monitored, and based on the amount of urine output, the furosemide is given to the patient. Or you wait, if the patient are randomized in the preventive group, you wait for SBT failure from cardiac origin, and then you can give diuretics to the patient. So we completed the study. We enrolled 422 patients. We don't have the results right now, but I'm hoping to have them very soon and to publish the result. So just to finish, I wanted to highlight the benefits and the risk of the diuretic strategy. Of course, trying to get a negative fluid balance as much as possible as a strong rationale. You see, you decrease the fluid balance, you get a better SBT success, higher probability of extubation, you decrease MV, you decrease the length of stay, better outcome for the patient. But the problem is that if diuretics are associated with hypokalemia, atrial fibrillation, hypotension, you would have to give more fluids, more vasopressor, so it's going to be a nightmare because at the end of the day, it won't be good for the patient. So maybe the question is not either it is good or not to give diuretics, but better to understand when we have to. This is what we wanted to test in the PCT study, and I really hope to give you the result very soon. Thank you very much.
Great talk. Thank you very much. Unfortunately, we do not have enough time for questions, and I'm really sorry we have to move on directly. Thank you so much. And so, how to prevent reintubation with Dr. Till. Thank you.
Thank you very much. It's always a great pleasure to discuss on winning, my favorite topic. And we will discuss now how to prevent reintubation. My name is Arnaud Till. I work at the University Hospital of Poitiers in France. How does it work? Okay, these are my disclosures. And thank you for people staying in the room while we are a little bit late, but I'm not guilty, not yet. And, so my disclosures mainly with Fisher and Paykel, New Zealand. So why should reintubation be avoided? And we saw this slide in the presentation by Oriol Walker, because mortality is very high in case of reintubation, around 25 or 30%. Obviously, patients who need reintubation are probably most severe patients, but we will see that we can change the rate of reintubation, we can change outcomes of our patients, and therefore we can prevent a reintubation. How to prevent reintubation? Maybe we can start with what should not be done to prevent reintubation. And for example, fasting the patient for several hours before extubation, and probably that many ICUs practice fasting before extubation around the world. And in this, a larger cluster randomized clinical trial performed in more than 1,000 patients in France in 22 ICUs, they compared fasting and continuation of enteral nutrition until extubation with reintubation as primary outcome, and they found exactly the same rate of reintubation at day 7, 17% in both groups. But in patients who were fasted, they observed delayed extubation, delayed ICU discharge, and more hypoglycemia. And therefore, probably fasting the patient for several hours should not be done before extubation to prevent reintubation. How to prevent reintubation? Maybe by performing a hard spontaneous breathing trial, for example, using a TPIS trial. And we know that work of breathing needed to breathe is higher with TPIS than with low levels of pressure support ventilation. But in this study, this Spanish study, including more than 1,000 patients, they compared a very hard trial, TPIS for 2 hours, and an easy trial, pressure support ventilation 8, without PEEP, for only 30 minutes. In all patients ventilated more than 24 hours. And what did they observe? Exactly the same rate of reintubation, 11% in both groups. But patients included in the pressure support ventilation group had a higher proportion of simple weaning, were more frequently extubated after only one spontaneous breathing trial. After this study, my question was, is it true in patients at high risk of extubation failure? Therefore, we conducted this study in nearly 1,000 patients at high risk of extubation failure, meaning an age of more than 65 or with underlying chronic or cardiac or respiratory disease. And again, we observed nearly the same rate of reintubation, 14% and 15%. But again, we observed that a higher proportion of patients had simple weaning using a spontaneous breathing trial with pressure support ventilation. And a lower proportion with PSV had, a lower proportion of patients had prolonged weaning. Therefore, I think and I strongly believe we can recommend a first spontaneous breathing trial with pressure support ventilation with a low level around 7 or 8 centimeters of water without off-PEEP. So how to prevent reintubation? Probably by performing alveolar recruitment before extubation. And in this Spanish study, they observed that patients who were reconnected to mechanical ventilation for 1 hour after successful spontaneous breathing trial had decreased risk of reintubation as compared to the others. Why? Why? Possibly because spontaneous breathing trial is associated with a marked alveolar recruitment, a loss of lung volume, with both pressure support ventilation or TPIS, but markedly more pronounced after a TPIS trial. As you see, a loss of lung volume of nearly 0.5% of lung volume recruited at the end of the spontaneous breathing trial. And we can see in this physiological study, because we measured end expiratory lung volume at different times, that lung volume was completely recovered after 1 hour of reconnection to mechanical ventilation. Another point, how to prevent reintubation? Maybe by preventing upper airway obstruction. This is a very difficult topic. What do we know? That steroids can decrease the risk of stridor at the bottom, the risk of reintubation at the top and at the bottom, but may delay extubation, because in this study, they applied a protocol of steroids for at least 12 hours, and possibly patients were extubated 1 day after. Therefore, how can we do? Maybe by performing a cuff leak test, by deflating the cuff, and by measuring the expiratory tidal volume to assess leaks around the endotracheal tube. And we know that there is a high risk of stridor in case of no leaks. But we also know that there is a low sensitivity, meaning that patients may have stridor while they have a high level of leaks before extubation during the cuff leak test. And maybe, in my opinion, the best way would be to have an homogeneous strategy in your unit. For example, we perform cuff leak test in all patients, but you could choose to perform cuff leak test only in patients at high risk, for example, women, traumatic intubation, prolonged duration of mechanical ventilation. But we perform cuff leak test in all patients by manual occlusion of the endotracheal tube with the thumb, or by measuring expiratory tidal volume in volume control ventilation. And in case of no leaks, we administer prednisolone, 1 milligram per kilogram, and we extubate the patients 6 hours later. And as we have a protocol driven by nurses initiating early the first spontaneous breathing trial, we can extubate the patient during the afternoon and not one day after. But again, I think the most important is to apply a homogeneous strategy regarding the risk of upper airway obstruction in your unit. How to prevent reintubation? Obviously, by applying prophylactic non-invasive respiratory support. And in this study, including more than 600 patients, we compared at high risk of extubation failure, age, cardiac disease, respiratory disease. We included patients to receive high-flow nasal oxygen alone or high-flow nasal oxygen and non-invasive ventilation with reintubation as primary outcome. And we observed decreased risk of reintubation with non-invasive ventilation, prophylactic non-invasive ventilation. Prophylactic means immediately applied after extubation in order to prevent post-extubation respiratory failure and reintubation. NIV was applied with a pressure support level of 8, PEEP 5, and for 13 hours within the first 24 hours after extubation. These results were confirmed by Gonzalo Hernandez in Spain, and in a population of patients at very high risk, meaning accumulating several risk factors of extubation failure. And again, in this population, they observed that NIV was associated with decreased risk of reintubation as compared with high-flow nasal oxygen. Maybe a particular population, obese patients, and Gonzalo Hernandez published recently a paper, a very nice paper in the Blue Journal. We have 3 clinical trials. The first one, ours, but it was a postdoc, but we see, we can observe decreased risk of reintubation with NIV as compared with high flow. A second study by De Jong, the largest study, it was not significant, but significant after per protocol analysis, and they included a high proportion of patients with short duration of mechanical ventilation, where a situation where non-invasive ventilation is not so effective. And the third study by Hernandez, where they observed a big difference between NIV and high flow, but this study was probably underpowered and they did not observe significant effect. And therefore, this is statistical opinion versus clinical opinion. I'm a clinician, and in my opinion, there is probably a major effect of non-invasive ventilation for these patients, obese patients, for preventive non-invasive ventilation. Therefore, guidelines recommend in patients at high risk, and I would like to add patients also with obesity, prophylactic non-invasive ventilation with moderate certainty of evidence. In patients at low risk, and I would like add, and with hypoxemia, the experts suggest the use of high-flow nasal oxygen, but with a low certainty of evidence. Why a low certainty of evidence? Because we have contradictory results. A first study, again by Gonzalo Hernandez, the star of winning, showing that patients treated with high-flow nasal oxygen had decreased risk of reintubation as compared with standard oxygen. And another study, an Italian study, where reintubation rates did not significantly differ between both groups. But in this study, they, however, observed that patients treated with high-flow nasal oxygen had less frequently NIV used as rescue therapy in case of respiratory failure. Therefore, a secondary outcome in favor also of high-flow nasal oxygen. The last point, maybe sleep, and by promoting sleep after extubation. And recently, we performed this observational study, a physiological study. We recorded sleep in around 50 patients after extubation. A low number of patients because polysomnography is very difficult in ICU, and we found a trend, just a signal, a trend for an increased risk of reintubation in patients with no REM sleep. REM sleep for rapid eye movement sleep, an essential stage of sleep during which occurs dreams, an essential sleep for neural comportamental restoration, and probably a signal to improve our knowledge on sleep and to improve sleep in patients in ICUs. And to do that, our neurophysiologist, Xavier Drouot, developed a micro EEG electroencephalogram located on the patient, microsystem, relatively comfortable, and we can have at the entrance of the womb connected by Bluetooth with a tablet computer, we can now, if the patient is sleeping or awake, and then if the patient in the tablet indicates that the patient is asleep, we can report non-urgent nursing care, reduce noise, light, etc. And probably it's very interesting to have a dedicated system, easy to put, easy to record and sleep. And we have a report every morning to assess sleep duration of our patients, and probably we can improve our knowledge and our practices to improve sleep in these patients after extubation, but at any time in the ICU. Therefore, in conclusions, a hard spontaneous breathing trial with a TP, so fasting the patient for several hours, should probably not be done in order to prevent reintubation. Probably that reconnection to mechanical ventilation for 1 hour, probably that steroids, again, in all patients at risk, after Kerflick test, regardless, but you have to choose your strategy. Probably that non-invasive respiratory supports are very useful, high flow and especially non-invasive ventilation in patients at high risk of extubation failure to reduce reintubation rates, and maybe in the future by promoting sleep. Thank you very much. No question?
Thank you.
Okay.
So thank you very much to everybody. I'm so sorry. Thank you.